Good morning. I'm about to begin. Indicate if you can hear me. Okay, we're continuing with Module 7, which is Traumatic Emergencies, specifically Chapter 30, Abdominal and Genitourinary Injuries. Introduction. The abdomen is the major body cavity extending from the diaphragm to the pelvis. And within the abdomen, you have organs that will fall within the peritoneum, organs that will be behind the peritoneum, and organs that will be located within the pelvis. So it's three compartments you have to think about. The peritoneum is the membrane that is around the intestinal structures. Retro is behind, so that's the kidneys. And within the pelvic region, you will find the structures of the reproductive system. So the abdomen is the major body cavity extending from the diaphragm to the pelvis. It contains organs that make up the digestive, urinary, and genitourinary systems. Important for EMT to know anatomy and function of the abdominal and pelvic cavities. Introduction, continuing. Significant trauma to the abdomen can occur from blunt trauma, penetrating trauma, or a combination of both. Injuries to the abdomen that go unrecognized or are not repaired in surgery are the leading cause of traumatic death. So it's a very large compartment. You have solid organs within that area, and you have your hollow organs. Hollow organs will spill their digestive juices, which can cause irritation that leads to peritonitis. Solid organs, when damaged, they are highly vascular, so that will lead to significant blood loss. 10% of all trauma patients have some form of genitourinary tract injury. Abdominal quadrants. Abdomen is divided into 4 general quadrants. Quadrant of bruising/pain can delineate which organs are involved. So within the right upper quadrant, you have the liver, the gallbladder, duodenum, pancreas. In the left upper quadrant, you have the stomach and spleen. So it's very important for you to note that the liver is on the right side, right upper quadrant. Spleen is on the left. These are 2 highly vascular organs that, if they are injured, can bleed significantly. Lower left quadrant, you have the descending colon, left transverse colon, and in the right lower quadrant, you have the large and small intestine and the appendix. Right lower quadrant is a common location for swelling and inflammation. The appendix is a source of infection, and if it ruptures, it can be life-threatening. We will discuss that more when we cover the medical component to this chapter. Hollow organs. So the hollow organs include stomach, intestines, ureters, bladder. Most contain digestive food, urine, or bile. When ruptured or lacerated, the contents will spill into the peritoneal cavity. That's within the membrane of the abdomen. It can cause intense inflammatory reaction and infection. This is what we call peritonitis. Itis is inflammation. Inflammation is swelling, leakage of fluid. The intestinal blood supply comes from the mesentery. It connects the small intestines to the abdominal wall. Patients with injuries to the mesentery can bleed into the peritoneal cavity. So there can be an issue with bleeding, and there can be an issue with irritation or inflammation, depending on the type of organ that is damaged. Bleeding will occur more from the solid organs and the blood vessels. The irritation will occur more from hollow organs rupturing. Ensure that you know the difference between your solid and hollow organs. Solid organs: liver, spleen, pancreas, kidneys. Perform the chemical work of the body: enzyme production, blood cleansing, energy production. Because of rich blood supply, if damaged, they can cause significant bleeding or hemorrhaging. Now let's look at the injuries that can occur. That was a brief review of the structures, the anatomy, and the function. Things that you should already know at this point. Injuries to the abdomen. Injuries to the abdomen are considered either open or closed. Can involve hollow or solid organs. If it's a hollow organ, they spill their contents. These contents can result in irritation or infection. Patient gets peritonitis. If it's solid organs, the risk, because they are highly vascular, the risk for excessive blood loss is present, and this can be life-threatening. Closed abdominal injuries. Blunt trauma to the abdomen without breaking the skin. MOIs include steering wheel, bicycle handlebars, motorcycle collisions, falls. There can be compression, poorly placed lap belt, being run over by a vehicle. There can be deceleration issues, fast moving vehicle strikes an immovable object and suddenly comes to a stop. Signs and symptoms that you need to be looking out for. Pain can be deceiving, often diffuse in nature, may be referred to another body location. So a patient can receive an injury to the right upper quadrant where the liver is, and they are complaining of pain in the right shoulder. That's what we call referred pain. Patient can get injured, get a blunt force trauma to the left upper quadrant, and they are complaining of pain to the left shoulder. That's referred pain. If a patient has referred pain to the right shoulder after being hit in the right upper quadrant of the abdomen, that's a suspected liver issue. On the left side, it would be the spleen, because it has to do with the nerves being linked. Blood in the peritoneal cavity produces acute pain in the entire abdomen. Now, signs and symptoms. It is difficult to determine the location of pain. Difficult to determine the location of pain. If you're not able to hear me at this point in time, you're having a connection issue on your side, not on my side. Difficult to determine location of pain, guarding, stiffening of the abdominal muscles. So guarding is when there's injury to the abdomen and the muscles go into spasm to protect the area. That can be considered guarding. The other thing that can be considered guarding is the patient trying to protect the area, physically trying to protect the area from being touched. Abdominal distension is often the result of free fluid or organ content spilling into the peritoneal cavity. Abdominal bruising and discoloration may be present, may appear as an abrasion initially. Seatbelts prevent many injuries and save lives, may cause blunt injuries of abdominal organs, particularly when belt lies too high, can cause bladder injuries to pregnant patients. You can look at that diagram when you're going through your text or the PowerPoint. Let's look at the open abdominal injuries. Foreign objects enters abdomen and opens peritoneal cavity to the outside, also called penetrating injuries. This can include stab wounds, gunshot wounds, accidentally being impaled by something, a board, a pole, fish gun. Open wounds can be deceiving, maintain a high index of suspicion. Now, the type of damage that occurs will depend on the velocity of the object. It can be low velocity injuries, which is associated with knives or other edged weapons. It can be medium velocity injuries, which is associated with smaller caliber handguns and shotguns. It can be high velocity injuries, which is associated with high powered rifles and handguns. High and medium velocity injuries have temporary wound channels caused by cavitation. So there can be temporary cavitation from a gunshot wound, from the bullet, and there can be permanent cavitation. The difference is temporary cavitation is created by the pressure wave around the bullet. So when a bullet leaves a handgun or a rifle, it rotates, it spins when it's traveling. As it spins, it creates a pressure wave around it. When it enters the body, that pressure wave will temporarily move structures from their normal anatomic position. But as soon as the bullet moves and the pressure wave subsides, the organs return to that position. Permanent cavitation is the path that the bullet takes, the exact path, that is the permanent cavitation. So high and medium, high and medium velocity injuries have temporary wound channels caused by cavitation. Cavity forms as pressure wave from projectile transfers to tissue, can produce large amounts of bleeding. Low velocity injuries also have capacity to damage organs. Internal injury may not be apparent. If injury is at or below the xiphoid process, assume it has affected the thoracic and peritoneal cavities. And in EMS, there is a simple rule. If you are concerned about the abdomen, then you should be evaluating the chest. And if you're concerned about the chest, you should be evaluating the abdomen. So we always assess both depending on which one there's an issue with. Continuing with open abdominal injuries. Now the evisceration is a wound in which the bowel protrudes from the peritoneum. So the bowel protrudes outside the membrane of the peritoneal cavity. Can be painful, visually shocking. Do not push down on the abdomen, only perform visual assessment. Cut clothing close to the wound. Never pull on clothing stuck to or in the wound channel. Signs and symptoms. Patient will present with pain. Patient can have tachycardia. Heart rate increases, pumping action to compensate for blood loss. Later signs include evidence of shock, change in the patient's mental status, and distended abdomen. Distended abdomen is a late finding. Hollow organ injuries often have a delayed signs and symptoms, right? So this is the organs that will spill their contents into the abdomen. Infection develops, which can take hours, so it can be hours or it can be days. Stomach and intestine can leak highly toxic and acidic liquids into the peritoneal cavity. Both blunt and penetrating trauma can cause hollow organ injuries. Blunt trauma causes organ to pop, releasing fluids and air. Penetrating trauma causes direct injury. Gallbladder and urinary bladder can also be damaged, and contents can cause issues inside of these organs. Right? So if the contents of the gallbladder spill out and the contents of the urinary bladder spill out, they can cause irritation and complications. Air in the peritoneal cavity can cause pain. You will not come across this in your literature for your level, but it is possible to get a pneumo. Well, let me not go there. I don't want to confuse you guys at this stage. So air in the peritoneal cavity causes pain. It can cause ischemia. If ischemia is not corrected, that will lead to infarction. And by now, we should know the difference between ischemia and infarction at this stage. Solid organ injuries can bleed significantly and cause rapid blood loss. Right? Can be hard to identify from physical exam. Slowly ooze blood into the peritoneal cavity. So because the peritoneal cavity is so large in size, when bleeding starts to occur, it is not readily noticeable because the space is not filled as yet. But as soon as that space is filled and you can see signs of deformity, it might be too late for that. Sorry, sign of a distended abdomen. It might be too late at that point. So you have to look for subtle signs. Look for discoloration around the navel, discoloration over the flanks, pain, referred pain to the shoulders, right or left, pain to the back where the kidneys are. So look for subtle signs and symptoms. Liver is the largest organ in the abdomen. It is vascular and can lead to hypoperfusion, often injured by fractured lower right rib or penetrating trauma. Referred pain to the right shoulder is a common finding with an injured liver. Spleen and pancreas. Vascular and prone to heavy bleeding, specifically the spleen. Spleen is often injured via or within motor vehicle collisions, steering wheel trauma, falls from heights, bicycle, and motorcycle accidents involving handlebars. Diaphragm. The diaphragm, when penetrated or ruptured, loops of the bowel invade the thoracic cavity. So if there's a opening in the diaphragm, the negative pressure inside of the chest can start to pull the intestine into the thoracic cavity, and the patient can actually get what is called or referred to as a tension gastro thorax. Not something that you need to be familiar with at your level, definitely for paramedics or higher. Kidneys can cause significant blood loss. Common finding is blood in the urine. That's referred to as hematuria. Blood visible on urinary meatus indicates significant trauma to the genitourinary system. Now, the patient assessment of abdominal injuries. Assessment of abdominal injuries is difficult. Cause of injury may be apparent, but resulting tissue damage may not be. So you may be able to identify the mechanism involved, but it might be difficult for you to determine specifically what has been damaged. That's not something you should aim for in the field. What you should aim to do in the field is determine that, is this a significant MOI or is it an insignificant MOI? That's what you need to be wary of. Worst case scenario, anything that is going to kill a patient with abdominal injuries quickly is going to be as a result of excessive blood loss. If it is the hollow organs, there is some time because infection and inflammation will take some time to build up. It can be hours, days after. So if there is signs of shock immediately, you should be thinking about excessive blood loss. So again, assessment of abdominal injuries is difficult. Causes of injury may be apparent, but resulting tissue damage may not. Patient may be overwhelmed with more painful injuries. Some injuries develop and worsen over time, making reassessment critical. So it's very important that if you have a patient with suspected abdominal injuries, your reassessment is on point. Scene size up. Standard precautions of gloves and eye protection should be a minimum. Be sure the scene is safe for you and your crew members. Call for additional resources early if needed. So if you think you're gonna need ALS, request ALS early. If you're in an area, and I'm talking about Jamaica now, and you're considering to transport the patient to a particular hospital that might not have the required surgeon readily available, then you need to call ahead that they can request that person. Because some of these physicians are on call. They are not physically at the hospital. Mechanism of injury, nature of illness. So mechanism of injury would be specifically for trauma. Nature of illness is your medical patient. Observe the scene for early indicators of MOI. Consider early spinal precautions. If the wound is penetrating, inspect object of penetration. Primary assessment. Perform rapid scan. Helps establish seriousness of condition. Some injuries will be obvious and graphic. Others will be subtle and go unnoticed. Injury may have occurred hours or days earlier, and usually, if they're having complication of hours or days earlier, you start to think about infection, you start to think about peritonitis. Form a general impression. Important indicators will alert you to seriousness of condition. Don't be distracted from looking for more serious hidden injuries. Check for responsiveness using a VPU scale. Address life-threatening external hemorrhage before airway and breathing concerns. Airway and breathing. Ensure airway is clear and patent. If spinal injury is suspected, prevent patient from moving. Clear airway of vomitus. A distended abdomen may prevent adequate inhalation. Providing oxygen will help to improve oxygenation. Circulation. Superficial abdominal injuries usually do not produce significant external bleeding. Internal bleeding can be profound. So what is going to kill this patient is the internal blood loss. Rarely they will produce significant external bleeding. So internal bleeding can be significant. Trauma to the liver, kidneys, and the spleen can cause significant internal blood loss or bleeding. Evaluate pulse, skin color, temperature, and condition to determine the stage of shock. You will check the peripheral pulse if your patient is communicating with you. If the patient is not communicating, carotid pulse. When you're checking the skin color, you check peripherally first. So you check the palms of the patient's hand. If there is changes peripherally in skin color, then you need to check for that centrally. What is the color of the patient lips? What is the color of the patient membrane? Can check the eyelids. Treat for shock aggressively if present. Transport decision. Abdominal injuries generally indicate quick transport to the hospital. Delay in medical evaluation may result in unnecessary and dangerous progression of shock. We cannot play around with these patients. Load and go, get them to the most appropriate healthcare facility as soon as possible, especially if you suspect that significant blood loss is occurring. Patients with abdominal injuries should be evaluated at the highest level of trauma center available. History taking. Investigate the chief complaint and MOI. Identify signs, symptoms, and pertinent negatives. Movement of body or abdominal organs irritates peritoneum, causing pain. To minimize this pain, patients will lie still with the knees drawn up. We call that the fetal position. So they tend to go into the fetal position to ease pressure off the abdomen to reduce the pain. History taking, sample history. Use OPQRST to help explain injuries. So once pain is present, all letters of the OPQRST must be asked. Ask if there is nausea, vomiting, or diarrhea. Ask about appearance of any bowel movements and urinary output. Secondary assessment. may not have time to perform in the field. Physical examination. Inspect for bleeding, remove or loosen clothes to expose injuries, maintain the patient's privacy as best as possible. Patient should remain in position of comfort, examine entire abdomen. Critical step for patients with entrance wound. So if there is a gunshot wound victim, you need to determine if they were shot more than once, where did the bullet enter, where is the exit, because the entrance might be small, the exit might be large, based on the principles of cavitation. Physical examinations. Use DCAP BTLS, inspect and palpate for deformities. Look for presence of contusions, abrasions, puncture wounds, penetrating injuries, burns. Palpate for tenderness and attempt to localize to specific quadrant of the abdomen. Do not palpate the area that is painful first. If you see pulsation in the abdomen, do not palpate. If there is an impaled object in the abdomen, do not palpate. If there is intestines outside of the abdomen, do not palpate. Look for the presence of contusions, abrasions, puncture wounds, penetrating injuries, burns, palpate for tenderness, and attempt to localize to specific quadrant of the abdomen. Swelling may indicate significant intra-abdominal injury. Palpate the quadrant farthest away from the quadrant exhibiting signs of injury and pain. Allow you to investigate the possibility of radiation of pain. That's why we do that. And we don't want to make them extremely uncomfortable right off the bat. Perform full body scan to identify injuries. If you find life threat, stop and treat it. Assess the need for spinal immobilization or spinal motion restriction. Inspect and palpate kidney area for tenderness, bruising, swelling, or other trauma signs. Hollow organs will spill contents into the peritoneal cavity. Vital signs within your secondary assessment. Many abdominal injuries can cause a rapid pulse and low blood pressure. Record of vital signs will help identify changes in condition. Use appropriate monitoring devices. Ideally, you want 3 sets of vital signs. The first one must be obtained before you leave the scene. So before you leave that location, you should have your first set of vital signs. If MOI suggests an isolated injury to the abdomen, focus your physical examination on the injured area only. Reassessment. Repeat the primary assessment and reassess vital signs. Reassess intervention and treatment. Interventions. Manage airway and breathing problems, provide spinal immobilization, treatment for shock, cover wounds. You will also do your communication and documentation in your reassessment. So communicate all relevant information to staff at the receiving hospital. Document results of physical exam and pertinent negatives. Describe scene in enough detail to give trauma team a clear understanding. Be cautious and diligent. when dealing with patients who refuse transport. Now let's look specifically now at emergency medical care of abdominal injuries. Closed abdominal injuries. Biggest concern is not knowing the extent of the injury. Patient requires rapid transport, primarily to trauma center with surgeons. You're going to transport the patient in the position of comfort once that is possible. Apply high flow oxygen. If signs of hypoxia or shock is present, treat the patient for shock. Patient with blunt abdominal wounds may have severe bruising of the abdominal wall. They may have liver and spleen laceration, rupture of the intestine, the mesentery can tear, rupture or avulsion of the kidneys, intra-abdominal hemorrhage, peritoneal irritation, and inflammation. Patients with blunt abdominal injury should be log rolled to a supine position on a backboard. Protect the spine, monitor the vital signs. That's closed. Open abdominal injuries, patients with penetrating injuries, generally obvious wounds, external bleeding. You're going to maintain a high index of suspicion for serious unseen blood loss. Surgeon should assess damage. Continuing with the open abdominal injuries. Inspect patient's back and side for exit wounds. If it's a gunshot victim. Apply dry, sterile dressing to all open wounds. If penetrating object is still in place, apply stabilizing bandage around it. Specifically for an evisceration, severe laceration of the abdominal wall may result in internal organs or fat protruding through the wound. Never try to replace a protruding organ. The objective is to keep the organ moist and warm. To do that, you will use an occlusive dressing, which is an ear-tight dressing. You put the occlusive dressing over the area, you tape 4 sides. Or you can put moist dressing over the area and then cover it with the occlusive dressing and tape 4 sides. If you don't have occlusive dressing, you can put the moist dressing, then put dry dressing over that and seal it. Now, so that's it for abdomen. Now, we're going into the genitourinary now. And it starts off with the anatomy and physiology. I will refer you to the lecture that Miss Nesbitt did. So ensure that you review the anatomy and physiology of the genitourinary system. Just go back to that lecture on the platform. Injuries of the genitourinary system. Kidney injuries. Not unusual and rarely occur in isolation. Kidneys lie in well-protected area. Forceful blow or penetrating injury is often involved. Suspect kidney damage if patient has evidence of any of the following: abrasion, laceration, contusion on the flank, that's to the side, right over the pelvic wing, penetrating wound in region of the flank or upper abdomen, fractures on either side of the lower rib cage or of lower thoracic or upper lumbar vertebrae, a hematoma in the flank region. Urinary bladder injuries may result in rupture, urine spills into the surrounding tissues. Blunt injuries to lower abdomen or pelvis can rupture urinary bladder. In males, sudden deceleration can shear the bladder from the urethra. In late trimesters of pregnancy, the bladder injuries increase. External male genitalia injuries. Soft tissue wounds. They are classified as soft tissue injuries or soft tissue wounds. Painful and of great concern for the patient, rarely life-threatening. Should not be given priority over more serious or severe wounds unless there is severe bleeding. For the female genitalia injuries, their reproductive system is mostly internal. Internal female genitalia, uterus, ovaries, fallopian tubes are rarely damaged. Exception is a pregnant uterus. Uterus enlarges substantially and rises out of the pelvis, which puts it at risk for injuries. So these injuries injuries to a pregnant uterus can be severe, and also keep in mind that it's carrying a fetus. And how it works is, if a woman is pregnant and her body starts to go into shock, her body will not try to protect her fetus. It's going to try and protect her. So if you can provide good management to the mother, you'll preserve the fetus. Female genitalia injuries continued. Still on, we're looking at the external female genitalia now. Vulva, clitoris, major and minor, labia, very rich nerve supply, considered sexual assault and pregnancy. If external bleeding, a sterile absorbent sanitary pad may be applied to the labia. Do not insert anything into the vagina. For the patient assessment of the genitourinary system, potential for patient embarrassment exists. You need to be very professional, maintain a professional presence, provide privacy as best as possible. It might be more appropriate for an EMT of the same gender, might not be possible in all cases. Look for blood on the patient's undergarment. Scene size up, scene safety. Assess the scene for hazards and threats. Assess the impact of hazards on care. Look for indicators for the MOI. Patient may avoid discussion to avoid undergoing physical examination. Patient may provide an MOI that seems less embarrassing than the actual MOI. Quickly scan patient to identify life threats. This is a primary assessment now. Genitourinary system is very vascular. When a system is very vascular, it means the potential for significant blood loss exists. Do not avoid this area in the rapid scan. Life-threatening hemorrhage must be addressed immediately. If bleeding is present, inspect exterior genitals for visible injury, form a general impression. Airway and breathing. Ensure the patient has a clear and patent airway. Protect from further spinal injury. Consider advanced airway if patient is unresponsive, right? So you need to be thinking about ALS, right? If you suspect that ALS is required, don't delay to request the ALS. If you're not in that type of setting, notify the hospital as early as possible. Choose the most appropriate hospital for the patient. Circulation. Genitourinary system can be a significant source of bleeding. Assess pulse rate and quality. Again, if the patient is responsive, peripheral pulse. Patient not responsive, go for a central pulse, the closest one to the brain, carotid. Closed injuries do not have visible signs of bleeding. Control bleeding if present. Transport decision. An injury to the genitourinary system can be life-altering, often requires medical specialists for specialized care. That's your primary assessment. Next, history taking. Investigate chief complaint. Common associated complaints with genitourinary injuries are nausea and vomiting, diarrhea, blood in the urine, vomiting blood, abnormal bowel, and bladder habits. In your sample history, you're going to obtain a sample history. Use your OPQRST if pain is present or letters. Ask the patient about output, especially blood in the urine. Ask about allergies. The importance of past medical history is very important. What they last had to eat, events. We know this by now. Sample. Physical examinations. Genitourinary system injuries can be awkward to assess and treat. Privacy is a genuine concern. Be professional. Focus on specific region of the body when isolated injury is present. Look for decap BTLS, identify wounds and control bleeding. Again, be professional in your approach, especially if it is a female. Don't get distracted. Secondary assessment, physical examination. Start with a full body scan for significant trauma. Presence of penetrating injury indicates possible internal injury. Presence of burns must be noted and managed immediately. Palpate for tenderness to localize the injury and the presence of fractures. Look for lacerations and swelling. In secondary, you're going to be obtaining your recorded vitals. Obtain the patient's vital signs. Important to reassess vital signs to identify differences in condition. Tachycardia, tachypnea, low blood pressure, weak pulse, and cool, moist, pale skin. These are all indicators of hypoperfusion or shock. Use pulse oximetry and non-invasive blood pressure devices when available. If you're using digital equipments, ensure that the patient presentation matches the equipment. We do not treat equipments, we treat the patient. Then your reassessment. Interventions. Provide oxygen if there are signs of dyspnea or shock and maintain airway. Control bleeding, treat for shock, place patient in position of comfort and transport. During this phase, you will be doing your documentation. It is what the patient tell you, what you observed, what you did based on your observation, how did the patient respond to what you did, method of transportation. That is how we report, that is how we document. Now let's look specifically at emergency medical care of genitourinary injuries. Kidney injuries. Injuries may not be obvious. You will see signs of shock and blood in the urine. Treat for shock, transport promptly, and monitor vital signs en route. For the urinary bladder injury, suspect if you see blood at the urethral opening, signs of trauma to the lower abdomen, pelvis, or perineum. In the presence of shock or associated injuries, transport promptly, monitor vital signs en route. For external male genitalia, make the patient comfortable as possible. Use sterile, moist compress to cover areas stripped of skin. Apply direct pressure with dry, sterile gauze dressings to control bleeding. Never move or manipulate foreign objects in the urethra. Identify and take avulse parts in bag to hospital with patient. Amputation of the penile shaft, it is possible. Managing blood loss is top priority. Use local pressure with sterile dressing. Surgical reconstruction is possible if you can locate the amputated part. If connective tissue surrounding erectile tissue is damaged, shaft can be fractured or angled. Sometimes requires surgical repair. Injury may occur during active sexual intercourse, associated with intense pain, bleeding, and fear. So the shaft of the penis can actually fracture. Laceration of the head of the penis. Associated with heavy bleeding, apply local pressure with sterile dressing. Skin of shaft or foreskin caught in zipper. If small segment of zipper is involved, try to unzip. If long segment of zipper is involved, cut the zipper out of the pants with heavy scissors. Urethral injuries are not uncommon. Straddle injuries, pelvic fractures, and penetrating wounds of the peritoneum. Important to know if the patient can urinate and if there is blood in the urine. Save urine for hospital examination. Foreign bodies protruding from the urethra will have to be surgically removed. Right, so urethral injuries are not uncommon, but you have to be considering straddle injuries, pelvic fracture, and remember, if a pelvic fracture is present, that is going to be a life-threatening injury. You also have to be considering wounds at lacerations or tearing at the perineum. The perineum is that area between the vaginal opening and the anus. If torn, it can bleed excessively. Avulsions of the skin of the scrotum may damage the scrotal contents. Preserve avulsed skin in a moist sterile dressing. Wrap scrotal contents or perineal area with a sterile moist compress. Direct blows to the scrotum can result in rupture of the testicle or accumulation of blood around the testes. Apply ice to the scrotal area. For the female genitalia, treat laceration and avulsions with moist sterile compresses. Use local pressure to control bleeding. Hold dressings in place with diaper-type bandage. Do not pack dressings into the vagina. Leave any foreign bodies in place after stabilizing with bandages. Injuries are painful but not life-threatening. In-hospital evaluation will be necessary. Transport urgency is going to be determined by associated injuries. the amount of blood loss, and whether or not your patient is showing signs and symptoms of shock. Rectal bleeding. Common complaint may present as blood in or soaking through undergarments. Possible cause include sexual assault, rectal foreign bodies, hemorrhoids, colitis, ulcers, colitis, I should say. Ulcers, rectal bleeding, possible after hemorrhoid surgery. And hemorrhoids are the blood vessels around the anal area. They become engorged. That's hemorrhage. That's hemorrhoids, I should say. Sexual assault. Sexual assault and rape are common. Victims are generally women, sometimes men and children. Often, there is little you can do beyond providing compassion and transport. Patient may have sustained multi-system trauma and need to be treated for shock. Do not examine genitalia unless obvious bleeding requires application of dressing. Follow appropriate procedures and protocol. Shield patient from curious onlookers. Document patient's history, assessment, treatment, and response to treatment. Follow crime scene policy of your EMS system. Advise patient not to wash, bathe, shower, douche, urinate, or defecate until after examination. If oral penetration occurred, advise patient not to eat, drink, brush teeth, or use mouthwash until after examination. Handle the patient's clothes as little as possible because it's going to be a source of evidence. Make sure EMT caring for patient is the same gender if possible. Treat medical injuries and provide privacy, support, and reassurance. And that is the end of genitourinary injuries. I will take questions now. So, any questions? Go ahead. Mr. Chantillo, what do you mean damping? Is damping a piece of cloth, rag, or gauze with sterile water and saline acceptable for what? Would it be acceptable for what? I don't understand the question. So you need to tell me what you mean by acceptable to do what? Moisture to organ. What do you mean? Give an example of moisture to organ. So your question is not clear. Clarify your question, Mr. Chantillo. Mr. John, had your go ahead.
Yes, sir. Chantillo. All right.
Yes,
You're saying that when the organ is exposed, you must try to maintain a moisture for the organ. So yes. I am asking, if using a piece of cloth or gauze, just for example, and we moisten it with either sterile water or saline, if that is acceptable.
You have cloth rag. You can't use a rag on the intestines. That's going to cut up the tissue. That's too coarse. If it's a piece of like a kerchief or a triangular bandage that's moist, that's fine. You can use that. But you cannot use something that is too coarse and put it over the intestine. You're gonna cut them up. That can cause issues. So was that about the moisture as well? So you had two parts. You had something about moisture and you had another part about using a cloth, or what was it?
Sir, the second one is coming from the first question that I was asking.
Oh, okay. Right.
So I use the second text as an example of the question that I was asking.
Got you. So I wouldn't recommend the rag. If you want to use a gauze, that's fine. Right? But once you put something that is moist over the intestine, then you need to cover it with something that's dry to maintain that moisture. Right? Just make sure that whatever you're using to put directly over the intestines don't damage the intestines, because we may have to improvise. That's a possibility. Mr. Johnson, you had your hands up. Go ahead.
Yes, sir.
Yes, go ahead.
Morning.
Morning.
How would the structure the
Find a mic that's working.
you hear me now, Chief?
Find a different mic. Your connection is low or weak, I should say.